Thank you very much. We shall go on to our last set of speakers, a wonderful topic, and let's all be glued to it. This is about Fuchs with early cataract. And we have Dr. Nikhil Gokhale, who heads the Gokhale Eye Hospital at Mumbai, and he's going to tell us phaco only makes sense. And Nikhil has been somebody I've had great regard and respect for over a couple of decades, and he knows about that. And I'm really happy to have him give this talk now. And the other person to contest him is going to be Dr. Praveen Krishna, who is the network director of the Technology and Communications of LV Prasad, and also the director of the Cornea Institute at LV Prasad. And he is going to tell combined procedure is the approach. And the expert view is going to be given by Dr. Namrata and this. So I would look forward to some question being answered by Dr. Shreyash or Charuta following this. And
thank you, Dr. Chitra. Yeah, thanks, Chitra, for the opportunity. So basically, I think when we talk of Fuchs dystrophy, there is still a lot of confusing information which the general ophthalmologist would face with regard to the nomenclature. So we have a very large subset of patients who undergo cataract surgery who have Guttata, and we can, just do the cataract surgery successfully and they don't progress in future. The tip of the iceberg is actually patients who have Guttata which continue to progress like a Fuchs dystrophy into stromal edema and epithelial and then scarring. So this subset of patient, definitely we have to think a bit louder as to whether we are going to do just a cataract or we are going to do a triple procedure. So this is something that we have to always keep in mind. So if we have maybe 10 patients of non-progressive guttate changes in our cataract surgery patient, we may have probably less than one patient who actually has a true Fuchs dystrophy, which will progress. The next question is that are we or are our ophthalmologists well equipped to distinguish the two entities? That means whether they can distinguish whether this guttate changes is just an isolated event or it's really a Fuchs dystrophy where you're getting corneal edema. And to do that, I think we all have to learn a good slit lamp examination, do specular reflection, specular microscopy, although as I'll show you, it's not very often helpful, and then do a tomography and a pachymetry profile to pick up subclinical stromal edema. This is what was traditionally taught to all of us, that if you have no epithelial edema, if the pachymetry is less than 600, there's no history of morning blurring vision, just do the cataract. And patients where you have epithelial or stromal edema with significantly thick corneas and scarring, maybe you would have to do a combined surgery. Also to stress that patients where the endothelium is poor, they may be very elderly, and if the vision is acceptable, better don't do anything and just leave them alone if they can manage with their vision. And also that severe Guttata can itself cause a drop in best corrected visual acuity because of scattering and glare at the posterior corneal interface. How we would see these patients or distinguish these options today is that if we have a patient, we need to analyze them, as I said earlier, and figure out if there is significant corneal edema with a clear lens, in which case you might even consider doing a endothelial keratoplasty alone. Whereas if there is a patient who has a significant corneal edema with a cataract, you might have to do basically a combined surgery. And then you have patients in between where there is no corneal edema, just guttate changes. You need to do only a cataract surgery. And for those where there is early edema, you can still do a sequential or a stage surgery. Now, what are the basic problems that we have when we say that we'll do a triple procedure or a EK, PK with a IOL? We need to understand we have only 1,000 cornea surgeons for our entire country. And if you look at the population which is aging, we have a significant volume of patients. If you look at 2022-23, about 83 lakh cataract surgeries were done. And if you consider that about 5 to 10% of this elderly population has guttate changes, so we had about 4 to 8 lakh of these patients who must have had guttate changes. We don't know how much Fuchs is, but if you in this elderly population, if you even consider to be 1%, then maybe 83% of these 83,000 of these would have had some sort of Fuchs dystrophy changes. We need to understand that only about 28,000 transplants were done in 22-23, many states and districts have no access to transplant surgeries, corneas, and surgeons. And throughout the country, only 4,500 EKs were done in 22-23. And we also have to understand that despite our best efforts, we can still have failures following an EK surgery. So we have plenty of patients, but we don't have enough corneas, nor we have the surgeons to handle all cases of Fuchs dystrophy. So if you are encountering a patient like this, I think we need to look at the age, vision, grade of cataract, stage of the dystrophy, surgeons' expertise, and the access to corneas. So I think the options, if you're working in a setup where there is no eye bank or there is no corneas or there are no corneal surgeons, possibly one option is to delay surgery. The other option is to do a careful cataract surgery. And the third option is, if the patient can afford, to refer him to a place where there is a good access to surgery, where they could decide whether they want to do a sequential or a simultaneous surgery. And also to say that a 618 with severe endothelial dystrophy and early cataract may be better than a hand movement due to a failed cornea in a patient who is unlikely to have an access to a transplant surgery. And that's the bitter truth in most rural areas of our country. So if the nuclear cataract is there, vision is fairly okay. One could safely defer surgery. However, if there is a dense cataract, vision is poor. One could do a phaco with a soft shell technique. However, in patient has got a very hard or a brown cataract, yeah, we can definitely do an SICS. And in those extremely complicated cases, I have no, I would often do an ECC in some of these patients, also to say that the surgeon's experience is the final guiding choice. When you do phaco, of course, you can use low flow technique, use BSS, minimize energy used, always prefer a hydrophobic IOL with a little bit of myopic target. And I still don't know the role of ROCK inhibitors, whether they really help or they don't help, we don't know. And when you're looking at stage surgery or combined surgeries, it's always, one would say that two surgeries, longer recovery and higher costs. However, the surgery would be technically less challenging, although in literature, the complications are very similar overall. However, we need to understand that some of these patients in the LVP, only 10% needed a EK 1 to 2 years after cataract surgery, whereas when you do a combined surgery, it's possibly much faster recovery. However, it could be more challenging and difficult. You could have more endothelial cell loss and more graft detachments. And we can have long-term failures over the next 10 or 15 years, which we still do not know. So I think also just to a word of caution that specular microscopy is most unhelpful in these most difficult cases. And that is something we need to keep in mind whenever we evaluate these patients. So I would say assess visual loss, do relevant imaging, understand your limitations, understand the limitations the patient has, whether he can travel, whether he has access to corneas. Talk to the patient, discuss options, counsel, and sometimes masterly inaction may be a good option for some of us. But of course, if you want to do a cataract, use the safest method and the best viscoelastics. And in the very severe cases, of course, do a combined procedure. Thank you.
Thank you, Dr. Nikhil. That was a wonderful talk.